Good evening. Assalamu alaikum rahmatullahi wa barakatuh. Thank you for all the attendees who have joined so far for this live webinar. Welcome everybody. Today we are gathered for a session which is run by the Young Leaders Forum under supervision of the Emirates Diabetes and Endocrine Society. It is a live webinar lecture, and in this lecture, it is CME accredited lecture, and the lecture basically it is recorded on the EDEC website. So, the webinar is live streamed on the Emirates Diabetes and Endocrine Society YouTube channel, and it can be obtained on demand on the Emirates Diabetes and Endocrine Society Institute website. And at the end of the lectures, the attendees can type in their questions in the Q&A box, and they can mention the speaker's name. I'm Dr. Ishma Ijazi, and I'm consultant internal medicine in Dubai Hospital. I graduated from Pakistan, did my initial certification in internal medicine from Pakistan, and after that, I obtained my Royal College MRCP examination from the Royal College of London, and followed by this, I have a specialty certificate examination in endocrine and diabetes, and also a postgraduate diploma in diabetes. I've been working as an internist in Dubai Hospital for the last 16 years. So today, we are lucky to have three very esteemed speakers from UAE, Dr. Fawzia Rashid, we have Dr. Alia Al-Shahi and Dr. Sumaya, and they will help us in furthering our knowledge on modern approaches in obesity management. So our first distinguished speaker is Dr. Fawzia Rashid, and who will give us updates on the management of the pharmacological management of obesity. Dr. Fawzia Rashid basically graduated from Pakistan. She completed her postgraduate in internal medicine, followed by a specialty certificate examination in diabetes and endocrine from the Royal College of Physicians. She also has an MSc in diabetes from South Wales. Currently, Dr. Fawzia is working as a consultant endocrinologist in Dubai Hospital. She's also a clinical associate professor at Mohammed bin Rashid University of Medicine and Health Sciences, and she's the associate editor of the Dubai Diabetes Journal and Endocrine Journal. So the floor is yours, Dr. Fawzia.
Good evening, everyone. Thank you so much, Dr. Ishma, for your introduction, and EDS and Young Leader Forum for your invitation. Ishma, that discussing about the obesity from it's something which currently in a very news about how to manage it and being the very important and prevalent disease. So the topic of my presentation is literature update on pharmacological treatment. But other than that, I'll be covering briefly just to develop a background and a pillar for my presentation that what is obesity, how to diagnose and screen and stage the obesity, some slide about the major international guidelines and the review of anti-obesity medication which are approved so far and the related trial data, and how to integrate this data into our clinical practice, and some other new emerging anti-obesity medication. So first question always come, and to avoid the confusion, I would like to compare some of the definitions proposed by different organizations. As per the World Health Organization, as per their statement released in 2025, obesity is a chronic complex disease, which is defined by excessive fat deposits that can impair the health status of an individual. While American Association of Diabetes ADA guidelines defined it as a chronic but often relapsing disease, which had numerous metabolic, physical, psychosocial complications, including the substantially increased risk of the development as well as the progression of the type 2 diabetes. So if we talk about what the other organization, which is one of the most common and the prevalent statements giving each year, is the European Association for the Study of the Diabetes. They mention is a very simple definition as an abnormal or excessive fat accumulation that can impair the health. Recently, the Lancet Commission come up with some interesting definition as a preclinical and clinical obesity based on the presence or absence of some obesity-related diseases and the complication per se. While American Association of Clinical Endocrinology just few weeks ago released their updated consensus guideline, and they defined obesity as a state of excessive adiposity with or without abnormal distribution or function of adipose tissue. So here I want to pause for a second and just to ponder about that, whether we are talking about the abnormal adiposity associated with or without any disease is a different definition, and they define it further as an umbrella term called ABCD, adiposity-based chronic disease. So someone or any individual who is having an abnormal deposition of the fat tissue, if they start having some diseases related, whether with their pharmacodynamics or definitely because of the mechanical impact, it is under the definition of ABCD. And they are further subdivided into adiposity-based chronic disease or the complication, CRD. So they further elaborated as a chronic heterogeneous neuroendocrine progressive and or relapsing disease, which is impacted by the or affected by the obesogenic environment, genetic susceptibility factor, and result in excessive or abnormally distributed adiposity, which can impair the overall health or even the survival. And why we should all be the concern about this? Because the prevalence of obesity is increasing at a pace that you can see that in 2010, about 1.6 billion individuals across the globe has been living, and it has doubled the figure now to approximately 3 billion of the adults living with that. So by 2030, we can expect the 3 billion adults having the adiposity-based chronic disease or obesity-based related chronic disease or the complication. And we can understand that how it is important to address at the preclinical stage this disease because of the validated data that obesity associated not only with the metabolic and the cardiovascular disease, it has a lot of functional impairment, quality of life, and psychosocial impact across the globe, as well as some incidences of the cancers are definitely associated with the impact of the obesity. And after understanding that what is adiposity or the abnormal adiposity-based disease, how to diagnose it. So there are certain surrogate measures of the obesity have been proposed, and they have been validated across the different studies and the data. And the most widely used proxy measure is BMI, which is known as body mass index, and it is the weight adjusted for the height. We all are familiar with that when we calculate the weight per kilogram and we divide it by the meter square of the height, we obtain body mass index. Other very well recognized parameters include waist circumference, and it predicts the development or progression of the metabolic syndrome and some metabolic disease, including diabetes, hypertension, and cardiovascular disease. Waist circumference has been validated as an index, but different across the gender as well as the ethnicity. For our Middle Eastern population, male should have below 94 and female should have less than 80 centimeter to call a healthy waist circumference. It differs across the Asian Pacific as well as the Caucasian individuals. The other very widely recognized and taking place into most of the studies as a uniform marker is the waist-hip ratio, which is we define as apple versus the pear-shaped body, and it should not be more than 0.9 for men and 0.85 for the women. Waist circumference is also widely checked, recognized, and multiple trials have been done to see the impact of the anti-obesity medication on the waist circumference, which is again a very important surrogate marker about the adiposities. And the waist to height ratio is more than 0.5 considered abnormal. Another less used and less validated marker include neck circumference and the body roundness index. So once we understand that we are checking obesity by different measures, because it's not possible to have the exact calculation of the adiposity, and it requires some body mass impedance or the MRI to exact calculation, the different abnormal or ectopic visceral fat. So the care model have been proposed by the latest guideline by the American Association of Clinical Endocrinology, which include that when you see an individual, you should screen them by calculation of their body mass index. When you establish a diagnosis that whether this comes into the normal BMI or abnormal BMI, you further look for their anthropometric components, which includes that you check for their waist circumference, or you can do their waist and height ratio to look for their excessive adiposity or assess that whether they have a normal adipose tissue distribution or no. And then third important screening parameter is to look for the clinical component, which includes the detailed family personal history examination and biochemical lab results to check the presence or the absence of obesity related chronic diseases, or if they are present, what is their severity. So all of this is part of our detailed evaluation for any patient we are suspecting they are suffering with the obesity related problems. So when we talk about the diagnosis established, we have to know that what stage of the obesity our individual is falling. So anthropometric component is one of the very important parameter to look into this. And as I mentioned earlier, that BMI and waist circumference varies across the gender as well as the ethnicity based differences are there. So one point to consider here is that when a particular individual you are looking, you have to look before labeling them overweight versus obese, that which ethnicity they belong to, because it is again validated by WHO that individual of the Asian Pacific region have a different classification for their threshold to classify as overweight versus obese. If they are between 23 to 24.9, they are overweight, considering it is considered healthier in the other individuals which are not belonging to the Asian Pacific origin. So different classes include class 1, class 2, class 3 obesity based on the BMI cutoff, and up to 35 is class 1, more than 35 to 40 is class 2, and more than 40 is class 3 obesity. And if you look here in the second chart, which is anthropometric measurements by looking into the waist to height ratio and waist circumference. Waist circumference is again depending on the ethnicity, and European, African, and Middle Easterns, they have the same waist circumference to classify. United States and Canadian have more than 102 and 88, and Asians and South Central American have much lesser waist circumference to call them abnormal adipose deposition. Waist to height ratio is one of the very important parameter because it is constant. It doesn't change as per the gender and the ethnicity. Another system which is suggested by the ESO is that you look for the staging by Edmonton Obese Staging System, which is actually the presence of the clinical or preclinical disease. That if someone is having obesity, but they do not have any medical, mental, or functional conditions, it is called stage 0. If they have mild condition, it's stage 1. If they have moderate and development of the comorbidity is there, it is stage 2. Stage 3 means that they have started having some organ damage. Stage 4 means they have end stage complication associated with their diseases. To further understand this for the Edmonton obesity staging systems, take example of an obese individual with hypertension or the diabetes. If they have a normal blood pressure, although their BMI is abnormal, it is called stage 0. If they start becoming pre-hypertension or pre-diabetes, is stage 1. If they develop full-blown diagnosis of hypertension and diabetes, is stage 2. If they develop, for example, congestive heart disease or LVH in the hypertension, and they develop macrovascular complication, is called stage 3. And if someone end up with the end stage complication, is called the stage 4 of the Edmonton obesity staging system. So why it is important, as the data have shown that up to 5 to 15% of the weight loss has associated with the reduction, even the reversal of these chronic complication of the obesity. And if we talk about the treatment, it used to be the intensive multi-component behavioral intervention and always been the first line and cornerstone major pillar of all the individuals which are living with obesity, because without change in the behavior, without a continuous motivation, multi-component intervention by both the behavioral therapist, nutritionist, and treating physician, it is almost impossible to achieve a major shift in their behavior and the change in their body weight. However, the studies have proven by the scale trial as well as the look ahead trial that the usual continuous motivatory change in lifestyle is short term, and we could not find that adherence is always maintained and result in a meaningful impact. So that's why the landscape of obesity management is under continuous evolution. This era has witnessed that the invention of the multiple pharmacotherapy has brought out the resolution in the symptoms and the complication. And this has given rise to a lot of hope to the medical fraternity across the globe. And the past approach, which was basically lifestyle-centric intervention, which have a short-term focus both by the therapist as well as the patient. And we used to have a single modality treatment. And the current approach, because of this paradigm shift, new inventions, and more awareness about the obesity treatment have lead to the model that obesity is not a condition, it's actually a disease, which is a chronic, it stays whole time, and it relapses. And long-term medical intervention is always required for our patient to get the meaningful result from our side. And pharmacotherapy has become a cornerstone of the impact we want to attain from our patient. So the understanding and management of obesity leads to the change in individual life, their caretaker life, and to the social structure of any society. This particular paradigm shift has led to one of the very astonishing scenes which is seen across the globe right now. And none of the disease has been witnessed that within a year, so many international organizations have come with the updated consensus statement within the short period of time. So if you see across the major guideline, they all have updated their statement just because of the evolution in the pharmacotherapy. And within the 2025 American Association of Clinical Endocrinology, European Association, Diabetes Canada, NICE, and all of them updated their consensus based on to the model of the ABCD, preclinical obesity or the clinical obesity. So if we talk about briefly what is the ACE summary is that they are lying onto the adiposity-based chronic disease framework, and it is an umbrella term, and they talk about that preclinical and clinical obesity based on the presence or absence of the complication, and they have make a hierarchical treatment plan based onto the patient preference, their disease status, and they have talked about long-term outcome-driven use as a target. NICE guideline, on the other hand, is basically person-centered, and they focus on behavioral intervention to keep an approach towards the patient and the family as non-stigmatizing, continuous motivation, and keep the pharmacotherapy as a multi-component. And if you do not achieve a meaningful result, stop it. ESO framework in 2025 has released a statement as that if you do not have a complication, you can decide the first line or second line treatment. And based on the certain comorbidities, you define the obesity as a fat mass or sick fat mass disease. Obesity Canada is the first one to address under the insurance cover obesity as a disease and to provide in many states of Canada a free coverage for the pharmacological therapy to all the patients who are eligible based on their BMI criteria and comorbidities for the selection of the drugs. So what are the so far approved anti-obesity medication right now? So if we look the major cornerstone of therapy right now lies onto the GLP-1 agonist or GLP plus GIP-1 agonist therapy. The most common molecule which is currently in use is semaglutide and tirzepatide. Semaglutide is approved with the name of Wegovy for obesity. Just for my audience to be clear that the same molecule is approved with the name of Ozempic, which is title approval for the diabetic medication, not for the obesity medication. And it starts with 0.25 milligram per week subcutaneous injection, and you can titrate it up based on the patient tolerance and response every 4 to 6 weeks up to the 2.4 mg maximum dose. And usual mean weight loss across the STEP program has been shown to be approximately 10 to 15% compared to the 2.4% in the placebo. The common side effects of all these classes related with the GI system, which includes nausea, vomiting, potential cholelithiasis, cholecystitis, and delayed gastric emptying. It has an absolute contraindication because of their boxed warning of thyroid season in rodents about the Mann syndrome, and to be cautious if patient have a history of the pancreatitis. Same goes for the tirzepatide, which is available with the name of injection Zepbound for the treatment of obesity. And the same molecule is available as a form of Mounjaro for the treatment of diabetes. So Zepbound starting dose is 2.5 milligram, and you can titrate it every month up to the 15 milligram subcutaneous weekly injection. The SURMOUNT trial has shown a tremendous results with the Zepbound, which is in many patient equivalent to their bariatric surgery outcome, and up to the average of 15 to 20% of weight loss has been achieved through the use of tirzepatide. It has the same side effect profile like the other commonly used GLP-1 agonist, and same contraindication it holds. The other GLP-1 agonist, which is liraglutide, is the first one to get approval for the obesity treatment, and it is available as a form of injection called Saxenda. Compared to the other one, it is a daily injection. It starts with 0.6 milligram daily, and you can titrate it up every week up to the 3 milligram based on the tolerance and symptomatology of the patient. It has been into the first line pharmacotherapy, and it used to get not more than 10% of the weight loss across all the trials, and it carries the side effect of nausea, vomiting, and same contraindication profile. Other approved anti-obesity medication, which were much earlier, than the GLP based therapy include the phentermine and topiramate combination. It is available as a brand name of Qsemia. So Qsemia approved in 2012 for the indication of obesity up to the age above 12. It is a centrally acting norepinephrine receptor agonist, and its starting dose is 7.5 to 46 milligram combination. You can taper it up based on the symptom. It has some side effect, including with the effect of norepinephrine action like paresthesia, dry mouth, insomnia, increased heart rate, and dysleucia. Absolutely contraindicated in patient who has a potential of getting pregnant, and because of the risk of teratogenicity, glaucoma, hyperthyroidism, and the recent use of monoamine oxidase inhibitor drugs. The other approved medication with the name of Contrave is a combination of naltrexone and bupropion. Naltrexone and bupropion is also approved quite early in 2014 for the indication of obesity. And it is also available as the low dose formulation, and it also allows you to taper it up based on the tolerance. And it achieves maximum weight loss up to 6 and to 8% by year one compared to 1 to 2% of the placebo. It also has some side effects because of the centrally acting work of nausea, headache, constipation, and dizziness. It has a strong contraindication in the patient who have severe psychiatric disturbance because of the increased risk of suicidality in these cases. And it's contraindicated in a personal history of seizure disorder, uncontrolled hypertension, chronic opioid use, bulimia, anorexia, or recent use of the MAOI inhibitor. One of the common drug which has been there before any other drug was given because of the availability over the counter is Orlistat with the name of Xenical. Xenical start at 60 milligram BID or TID with a meal, and you can go up to the 120 milligram. It is approximate loss 3 to 5% after the use of 1 year continuously. The limiting side effect with Orlistat is feeling of the fecal urgency, oily stool, and some loss of the fat soluble vitamins across the whole population. It is sometimes tolerated. Most of the time, it is not very well tolerated over the longer period of the time, and it's contraindicated in the patient who have some kind of chronic malabsorption syndrome, and some medicine can have interaction with the use of orlistat. One particular medication worth mentioning here as an approved medication, it's at melanocyte. It is available with the name of Imkivri. It has certain indication for its use, including the childhood obesity because of genetic forms, and it is started as a low dose and up to 3 milligrams of Q daily. It is associated with substantial loss of weight in genetic form of the obesity, and usually it is tolerated well, except some cases may develop nausea, diarrhea, and depression risk. But mind it is only for some specific kind of the obesity, which include the use only in cases where you have genetically diagnosis available for patients who have POMC deficiency, leptin receptor deficiency, Bardet-Biedl syndrome. There are some medication which has been approved by FDA only for a short-term use because of their potential side effects. It is only isolated agent of the phentermine and diethylpropion because they are all working through the norepinephrine, so they have a lot of side effects associated and can cause uncontrolled hypertension, risk of tachycardia, dry mouth, etc. So this slide is important because when we see a patient, we have to see their particular profile and how to monitor after the use of this medication. So this is in terms of, if you see here, the different agent and their effect on the gastrointestinal symptom, cardiovascular, psychiatric, hepatic. So GLP-1 receptor agonists are generally very safe, and they have a very high safety index. Most commonly, their mild to moderate GI effects are noted. And if we talk about GLP and GIP-1 receptor, again, the same GI effect is more prevalent. In terms of the Qsemia, because of the cardiovascular effect, it leads to increased risk of hypertension and tachycardia, and it has to be tapered down if someone is complaining that they are suffering with headaches and suffering with the increased blood pressure risk. Regarding the Contrave, again, the same GI side effect, increased blood pressure, and increased risk of psychiatric disorder worsening has been associated. We have to closely monitor the patient who have any tendency to develop depression. Orlistat have GI side effect, steatoria, and the cholestasis. So why GLP and GLP plus GIP-1 has been changing the paradigm of obesity management? We have number of the obesity trial in different group of patients and population across the world, and it has uniformly proven through those trials the effect of weight loss, which is uniform and with having the very large safety data available so far. So semaglutide through the program of a step uh, one has shown average weight loss of 15% versus placebo. And not only that, it leads to the sustained effect of the weight loss. So the efficacy does not lose with the continuous use of the semaglutide. And if we talk about tirzepatide, which is ZEP bound, through the SURMOUNT program, it also shows up to the 20% of the sustained body weight loss. And liraglutide through its scale program also shows up to the 10% of the body weight loss. These agents have been used in a subpopulation with specific adiposity related diseases like MASLD and MASH trials. So liraglutide in the lean trial showed some improvement and histological resolution of the MASH in a patient compared to the placebo. Semaglutide has completed a phase 3 trial, which is named as Essence trial, and it shows the resolution of NASH without change in the major fibrosis compared to 63 and 34% versus placebo. This trial has led to the recent approval of semaglutide for the patient with MASLD and MASH. And it is a breakthrough thing, and soon we will be getting an approval, hopefully, across the world for the same indication. Tirzepatide has an ongoing trial for the same subset of population with the name of Synergy NASH. The preliminary data from the tirzepatide also shows improvement and resolution of the NASH-related biopsy changes. Obstructive sleep apnea trial have been completed in tirzepatide with the name of OSC with obesity, and it showed a great reduction in the hypoxia index and SURMOUNT OSA trial. Semaglutide have a post hoc analysis of their STEP pooled trial, and it also showed that it leads to the hypoxia index reduction, but there is no dedicated RCT for that. Semaglutide has completed a trial step 9 knee osteoarthritis, and it showed that the score index, which is known as the WOMAC across the Canada and Toronto, 41.7% reduction compared to the placebo group. Liraglutide did not show the much change in the pain, but there is its core changes seen in the patient who use it. And tirzepatide have an ongoing trial. The results are expected next year. So summary of efficacy across the different indication, if we talk pure obesity without an existing chronic disease, tirzepatide is superior than semaglutide in terms of the superior weight loss. If obesity associated with CVD or CKD, semaglutide have shown superiority over the tirzepatide because of the proven flow trial and different CVD and the renal outcome benefits. MESL and MASH completed trial by semaglutide, OSA completed trial by the tirzepatide, and osteoarthritis by semaglutide. So this pure data has led across the guidelines from Europe, America, and Canada as a first liner, second liner, third liner agent. So if you see this slide here, the first line is by dark blue, second line therapy is the light, and third line is very light blue. So if someone is having pre-diabetes, metabolic syndrome, and you want to prevent the diabetes, the tirzepatide, semaglutide are the first line, followed by liraglutide and combination of phentermine and topiramate, and third line and orlistat. If someone already have a type 2 diabetes, which means that they are entered into the clinical obesity stage, the same hierarchy exists here. If you're dealing with someone who is suffering with osteoarthritis secondary to their adiposity, this is called the functional disorder, semaglutide has proven benefit in terms of their reduction in the pain score, which is a biomechanical disorder. So OA and OSA both have the proven efficacy through the tirzepatide and the use of semaglutide. If patient have coexistent MASH and fatty liver score is going towards the fibrosis, we have a proven benefit through the semaglutide reduction in the fibrosis score and resolution of the fatty liver disease. For the cardiometabolic dysfunction, for the MACE prevention, we have again semaglutide and tirzepatide proven benefits. All of these leads to a hierarchy of these two medication in the treatment of obesity with the coexistent comorbidities. So here again, ACE come for the lower cost pharmacological step therapy for ABCD. So there are countries where the insurance doesn't accept the pharmacotherapy for obesity. They do not accept obesity as a disease. Then ACE suggested an algorithm that if you have an stage 1 ABCD, you can consider first generation obesity medication, which are Contrave, Qsemia, and liraglutide, because there is still lower cost compared to the advanced therapy, which are semaglutide and the tirzepatide. However, if you are dealing with the stage 2 obesity or the stage 3 obesity, still you have to prefer the tirzepatide and semaglutide based on the proven benefit come across through all the trial program in the last 10 years. So medication for obesity, when you talk about individualization, is also come across a very good summary that when you select an individual, you have to see what you are looking for. Diabetes prevention, type 2 diabetes, hypertension, three agents have proven benefit. If you are looking for someone who is having only obesity and they want a low cost reduction, orlistat is a better choice. If you're looking for someone who has underlying psychiatric disorder, we have a big no for the phentermine and naltrexone based therapy. If someone have calcium oxalate stones and the history of nephrolithiasis, we cannot consider orlistat and the phentermine combination. Severe hepatic impairment, all of the medications are contraindicated except the GLP and GIP. And patient with pregnancy, none of the data is available. So we have to consider all of these factors. So all of these guideline pharmacotherapy hierarchy has lead to the different practice now, and we have to integrate into our clinical practice and how to implement this. So first step is always to assess your patient, look for their eligibility, look for their comorbidity assessment and risk stratify based on the ABCD staging. You will initiate the treatment which is appropriate for this particular patient. Start with your first line therapy. If patient cannot afford, you can go to the other medication which are available, though they may not be as successful in reduction of the comorbidities. And then the regular follow-up and monitoring is at most important because response assessment is very important as well as the management of the side effect. Because just remember, some of the side effects are well managed because of GI side effect, etc., by the other supportive measures. And when you have a proper integration of this pharmacotherapy, you involve patient. Remember that everything should be realistic. The goal setting should be realistic. We have to be in hand with the patient, and we have to look for the success factor based on the multidisciplinary team involvement. I cannot emphasize enough the role of nutritional and the behavioral modification for our outcome tracking. So when you do initiate, you have to do the dose titration and you have to monitor the response, because if you do not achieve an adequate weight loss, it means the pharmacotherapy is not working or patient is not compliant. If patient is not compliant, we have to look what is the cause of this suboptimal response. They are not tolerating because of the side effect, or they cannot afford it because still the economic burden and the cost of therapy is a major barrier. And if you have a more than 5% weight loss by the time 3 to 6 months, it means the medicine is working and you can continue to long-term therapy and you can taper it up as per the patient's wish to achieve the maximum possible response. And we have to remember that this is an individualized treat approach. We cannot push it, but if you want to attain, we can still go for the combination therapy after the adequate patient-related education. The presentation will not be complete if we do not talk about some of the medicine trial which are into the pipeline. There are tens of medication right now into many preclinical and the phase 1 trial, but the worth mentioning are those anti-obesity drugs which have crossed the phase 2 trial. One of the medicine which is looking for the approval and file has been submitted to FDA's oral semaglutide, which is a peptide-based oral GLP daily therapy, and it has proven through the US's trial program it's worth to be approved as a obesity medication. Another interesting molecule is a combination of the GLP-1 plus amylin analog with the name of cagri-sema. It is not yet approved, but it has, through the redefined program, again showed its value to be approved as an anti-obesity medication because of the very unique mechanism of action. Retatrutide is a combination of triple agonist, which is GLP, GIP, and glucagon. It is most talked about molecule because the so far systemic reviews and meta-analysis have proved that probably it will take the efficacy over all the approved medications so far available. And orforglipron is again a GLP, but it's a non-peptide form. So people are looking forward for that through the ATTAIN program, that it will also take superiority in terms of the management of the obesity. The other molecules are the same combination of GLP and GIP, including mazdutide, danuglipron, survodutide, and another very interesting molecule, which is a combination of the GLP-1 and GIP receptor antagonist, is the Maritime program, which is going on and entering into the phase 3 soon. It is not yet approved, but the data from the phase 2 trial have shown very remarkable and meaningful results. So my key takeaway message is that when you have a patient, you have to look for the obesity management by evaluating their body mass index, comorbidities, and their own eagerness and readiness. Initiate lifestyle therapy. Without that, we cannot achieve anything. Add pharmacotherapy if BMI is more than 30. But if more than 27 with comorbidities, you can still consider pharmacotherapy. Choose the pharmacotherapy based on the efficacy, safety, and the patient preference. Reassess always at 12 to 16 weeks and plan long-term follow-up based on the results you see after the first follow-up. Remember, obesity is a chronic and relapsing condition. It's not one size fit for all. It's not one thing given for all. It's something that you have to do dynamic stratification and review the suboptimal response based on the patient response. Guideline always talk about hierarchy, and now they are more talking about individualized long-term care because of long and wealthy data available now for the best outcome. So paradigm shift has taken place because of the high efficacy AOM available. Science has not witnessed so far that kind of splurge and evident medicines, which is really changing someone's life and improving their outcome. So recognizing obesity as a chronic disease, long-term treatment is a fruitful value for all the healthcare providers and is going to help the whole society and the nation as such. So we have to consider the importance of incretin-based multi-agonists now, and future outlook should be on the personalized medication based on the individual characteristics because of the diverse therapeutic options are soon to be coming onto the horizon for different patient needs. So remember, the cardiometabolic risk reduction, disease remission has been seen with the use of these medications. So I thank you all for your attention, and these are all my references.
Thank you very much, Dr. Fawzia, for this informative presentation. It was a very comprehensive literature review on the definition, the cutoffs for diagnosis, and pharmacotherapy for obesity. And I think you made a very thorough and a very meticulous comparison across all guidelines, including ADA, NICE, European, and Canadian guidelines. Thank you again, Dr. Fawzia.
Thank you, Ishma.
So, our next presentation will focus on childhood obesity and the challenges which are basically associated with the management of childhood obesity. Our next speaker is Dr. Alia Al-Shahi, who will discuss about a pediatric case of severe obesity. So, Dr. Alia is a pediatric endocrinologist fellow at Sheikh Khalifa Medical City. She is a graduate from United Arab Emirates University with a bachelor's degree in medicine, and she completed both Arab board and Emirati board certification in pediatrics. She's a dedicated, she's involved in specialized evidence-based care for children with endocrine disorders and is actively involved in research and medical education in the field of pediatric endocrinology. So, Dr. Alia, the floor is yours now.
Hello, all. كيف this? Let me share my screen with you. So I will be discussing a case of complex obesity that we faced recently in our center. The patient demographics, he is a 16 years old boy. He initially presented to our endocrine clinic on December 2023. He was referred from general pediatrics as a known case of Prader-Willi syndrome with type 2 diabetes mellitus, who was diagnosed in 2020. He was already in insulin MDI regimen of digludectin units daily and insulin lispro 7 units before each meal, and he was on a glucophage 1000 milligram BID, and he was referred to an endocrine clinic to optimize his type 2 diabetes management and his glycemic control. In review of system, the main positive symptoms that he was having snoring at night, and parents noted sometimes gasping of air during breathing while sleeping. He had limited walking distance because of feeling fatigue and easily tired. And he had difficulty to control his food-seeking behavior. He was stubborn. He had anger burst while trying to stop him from eating or limiting his oral intake. Moving on to his measurements, so we can see that his weight on the growth chart is exceeding the 97th centile. His stature is growing around the 10th to 15th centile, and his BMI as well is above the 97th centile. If we go specifically with his measurements, so his weight at this time, it was 110 kgs, and his BMI was 42.02 kilogram per meter square. His vitals initially were within acceptable limits. During the extensive physical examination for this patient, it was significant for the pubertal or genitourinary examination. He had 10R1 penis hidden in a fat, small scrotum, and testes at that time were not palpable. With the musculoskeletal examination, there was reduced range of motion, mainly on the lower extremities. And with the psychiatry evaluation, he was difficult to examine, not cooperative, trying multiple times to convince him to come inside the room initially and to conduct the physical examination. At that time, the only blood investigation that was done, it was the point of care HbA1c, which was 13.6% because he refused to do the rest of the blood test. So over the year of 2024, he was following with the endocrine clinic every 3 to 4 months. When the parents would come with each visit, it will be difficult to manage his diabetes because he was refusing to apply any CGM for glucose monitoring. He was refusing to do the regular bloods. He was refusing even the blood glucose check at home regularly at home. Over that time, his insulin regimen was adjusted until October 2024. So until he reached an insulin glycemic dose of 40 units daily, insulin Lispro 15 units before meals, a glucophage of 1000 BID, and he was started at that time on Victoza with 0.5 milligram daily. Moving on in November, the Victoza dose was increased from 0.5 to 1.2 milligram daily. 2 days later, he presented with ER with a severe abdominal pain. Initial labs to rule out pancreatitis were done, and they're within normal limits, and his blood gas was overall showing some acidosis. So his Victoza was stopped at that time. And after a few days, he presented again to ER with lethargy and difficulty breathing. He was experiencing hypercapnic respiratory failure, and he was managed with non-invasive ventilation in the PICU for 1 week. And at that time, because he was staying in the hospital, so extensive investigation and work up by MDT care was done. He was diagnosed to have obstructive sleep apnea, and he was started on CPAP machine. He was found to have hypertension and was started on lisinopril. He was found to have dyslipidemia and was started on rovastatin. His poorly controlled diabetes was followed, and based on that, his insulin regimen was adjusted, and his long-acting insulin was increased to 60 units daily. And at that time, when he presented, we can see that his weight over 1 year has increased from 110 to 145.05 kg, and his BMI has reached 56.17 kg per meter square. And the latest HbA1c in December 2024 was still poorly controlled with 14.1%. At that time, he was strongly recommended to readmitted to the hospital to have again an MDT care to better improve his diabetes control and his comorbidities. But the parents and the patient himself refused because of the difficulty with his behavior control to keep him in the hospital setting. The father reports continuous with difficulty in monitoring his glucose. And his insulin regimen was further adjusted. He was taking insulin Lantus 40 units BID. Humalog reached 20 units before meals. And he was started on dulaglutide, 1.5 milligram weekly, with glucophage dapagliflozin, 1,000 to 5 milligram BID. And he was continued on the hyperlipidemia and hypertension medication. He presented again to ER after a couple of months with increased work of breathing, hypercapnic respiratory failure, and was admitted again to the ICU. And as he refused the initial respiratory support, the subsequent days, the bedside nurse found him unresponsive, desaturating, and gasping for air. Based on that, he was intubated and he was shifted to IV insulin. 4th of March, after a month, he was extubated and shifted to his BiPAP. Insulin infusion was stopped and he was shifted to insulin subcut. And the dulaglutide was shifted to semaglutide 0.5 milligram weekly. At that time, he was planned for bariatric surgery, but postponed due to his severe clinical condition. So talking a little bit about the background of Prader-Willi syndrome, it is a rare and complex progressive disorder that affects multiple body systems. It is recognized as one of the most common causes of genetic obesity. It is caused by a deletion or disruption in the proximal arm of chromosome 15, and approximately the incidence of Prader-Willi is around 1 in 20 to 30,000 live births with equal male to female distribution. And the genetic background of Prader-Willi, as we said, it is disruption in the proximal arm of chromosome 15. 60% of the cases of Prader-Willi are due to deletion on the paternal chromosome. And 20 to 30% are caused due maternal uniparental disomy, where both copies of chromosome 15 come from the mother, and the result from errors during meiosis. And finally, 1 to 3% of individuals with Prader-Willi who have apparently normal chromosomes have imprinting defect. And Prader-Willi was the first of human disorders to be linked to genomic imprinting. It occurs when genes inherited from the father in chromosome 15 are not expressed due to various genomic mechanisms. Most genes in this region are subject to genomic imprinting, meaning only the father's allele are active, while the mother's allele are silenced through methylation. Usually, signs and symptoms of kids with Prader-Willi, they appear to have a complex dysregulation of the hypothalamus, affecting both the adeno and neurohypophysis. There is no specific genotype of Prader-Willi is linked to the exclusive symptoms, but a diverse range of clinical phenotype have been observed in patients with the main subtypes, the maternal uniparental disomy. In infants, the major symptoms include severe muscle weakness, weak cry, lethargy, difficulty feeding. Initially, they will have failure to thrive, and they might have a cryptorchidism in males or underdeveloped genitalia and labia in females. They will have distinct dysmorphic facial features, such as small hands and feet, narrow hands, and straight ulnar border. The signs and symptoms in children with Prader-Willi, they will, endocrine specifically, it will include short stature, growth hormone deficiency, hypothyroidism, central adrenal insufficiency, isolated precocious puberty, and or hypogonadotrophic hypogonadism. They will have distinct behavior profile. Some of them might have intellectual disability and cognitive rigidity, behavioral outbursts, severe anxiety, and increased risk of psychosis. During the childhood of a patient with Prader-Willi, they will shift from being hypotonic with failure to thrive to expressing hyperphagia and strong desire for food, and develop severe obesity along with various related complications of the obesity, such as type 2 diabetes, fatty liver disease, dyslipidemia, hypertension, metabolic syndrome, and cardiovascular disease. Additionally, individuals with Prader-Willi might experience scoliosis, kyphosis, or sleep abnormalities, including both central and obstructive sleep apnea. So, but the pathophysiology of obesity in Prader-Willi, there are multiple hypotheses have been entertained in the field. So they do experience insatiable hunger, so hyperphagia, with other compulsive behavior between the age of 2 to 5. And this could be related to the hypothalamic dysfunction. The functional brain imaging techniques that have been done for patients with Prader-Willi syndrome have shown that the orbitofrontal cortex is activated when individuals consume food until they feel full. And signals related to satiety and visceral cause within the orbitofrontal cortex is significantly influenced by food perception, resulting in response that reflects the food reward, value, or appeal. So the individuals with Prader-Willi syndrome have been found to have altered orbitofrontal cortex response to satiety in functional brain imaging studies. Other pathophysiology for the obesity in these individuals include elevated levels of ghrelin and oxytocin. Even in compare to obese control that have been described. The ghrelin abnormality may contribute to hyperphagia and food-related thoughts and cravings, while the oxytocin dysfunction affect the emotional processing and appetite regulation. Both are which involved in the addictive behavior that these individuals have. And these hormones not only impact the hypothalamus and limbic system, but also influence the olfactory bulb. And the olfactory system plays a crucial role in nutrition and social behavior. It can trigger specific appetite for relevant food. It is known as a sensory-specific appetite. So a study involved adults with Prader-Willi revealed abnormal brain reward system activity, particularly at the right amygdala level in response to food odor. And these individuals of Prader-Willi have elevated level of hyperadiponectinemia. They have hypoinsulinemia with lower level of PYY and associated with leptin and insulin resistant at the blood-brain barrier, which ultimately leads to which decrease the satiety at the hypothalamus system. So in general, the treatment of obesity in Prader-Willi syndrome, it is an MDT care. The conventional treatment is initially to start growth hormone therapy early to increase their muscle mass while decreasing their fat mass, and behavioral therapy to strict supervision of food intake and caloric restriction. And in the literature review, there have been tried other options as a treatment of obesity in Prader-Willi syndrome. One of these articles is this one. This study includes two parts. The first part, it's a literature review of PubMed to check for the medication that have been used for the treatment of obesity with Prader-Willi syndrome. And the other part of this article discuss a case series for 10 patients who have been studied in a single multidisciplinary Prader-Willi clinic who have been on medication. So the literature review in this study yielded 14 articles, included 3 studies on topiramate, 1 on metformin, and 4 on liraglutide, 5 on oxytocin, and 1 on naltrexone bupropion. So as we can see here, these are the studies that have been included. So as we can see here, the most as we said, 3 patients has topiramate. 1 patient had metformin. 1 study had 3 studies had liraglutide. And 5 studies has oxytocin. So the most promising effect on weight loss in the literature review have showed was related in the liraglutide effect with other anti-obesity medications such as metformin and empagliflozin, while all the 4 demonstrating decrease in HbA1c and variable effect in weight without side effect. The 3 articles on the topiramate showed positive change in mood and hyperphagic behavior, with only 1 showing satisfactory significant weight loss. The most common reported side effect in the study was increased somnolence, whereas metformin also showed improved in hyperphagia without weight loss. The articles on the oxytocin showed inconsistent effect on behavior, which ranged from improved hyperphagia and social behavior to sadness to no effect. There were no changes in BMI or weight. Side effect included nasal irritation, negative effect on behavior, outburst, and anger. The case report, the last one shown in the table related to the naltrexone bupropion, showed decreased BMI and aggression without side effect, but this result is limited to only 1 patient of case report. The other part of the study included a case series. It was a retrospective cohort review of single urban tertiary care MDT of Prader-Willi Clinic database. It was conducted for all patients with Prader-Willi from a period of July 2018 to June 2021. And they included patients who were pediatrics, so 18 years or younger, and who had confirmed Prader-Willi syndrome, who had a measurement that were done at least for 12 months, and who had a BMI which was equal or greater to 95th centile, and who were on anti-obesity medication, and who had at least took these anti-obesity medication for 12 weeks. And after the 3 months of monotherapy, if greater than 5% weight loss is not achieved, these patients were shifted to a trial of combination therapy. So a total of 10 patients met the inclusion criteria and included in this case series. 6 patients were in full dose metformin, 1,000 milligram twice daily. All 6 completed a 16-week course of metformin. Only 1 case, which is case 1, had a decrease in BMI after a 4-month course of metformin, with a change of BMI of minus 0.35 standard deviation. And even after 24 months of continuing on metformin, a sustained weight loss during that time have been achieved. 1 patient maintained their BMI during the metformin course, which is case 3. The remaining 4 cases, which are case 5, 6, and 8, and 10, overall had increased in their BMI. So parents of these patients reported improvement in food-seeking behavior, hyperphagia, appetite, and impulse to eat. And the cohort, the following patient completed a combination of anti-obesity medication. So case 5 initially was on metformin, and then they added topiramate and semaglutide. Case as well 7, they had a combination treatment of topiramate and liraglutide. Case 8 had metformin and topiramate, and case 10 had metformin and liraglutide. And liraglutide, there was a significant reduction, mainly with the liraglutide and semaglutide addition with the anti-obesity medication. Another study that have been done to test the diazoxide choline extended release tablet in people with Prader-Willi syndrome. This is a double-blinded placebo-controlled trial. They call it the Destiny the Prader-Willi syndrome trial. It was a 13-week randomized double-blinded placebo-controlled trial, phase 3. It included 127 participants with Prader-Willi aged 4 years or older, and they had hyperphagia. These participants were randomly assigned 2-to-1 to diazoxide choline extended release tablet or to placebo. So why to use extended release diazoxide as a treatment of Prader-Willi syndrome? Diazoxide acts mainly on the adenosine triphosphate sensitive potassium K channel, and it crosses the blood-brain barrier, activating the KATP channel and the NPY and AGRP neurons in the hypothalamus, result in reduced secretion of these elements, and potently increase the appetite stimulation and neuropeptide potential, contributing to a reduction in the hyperphagia. So these action of the drug are completed by activating the KATP channel in the dorsal motor nucleus of the vagus and the pancreatic beta cell and adipocyte to reduce the hyperinsulinemia and excess body fat and improve insulin and leptin resistance and satiety. So these patients were randomly and double-blindedly placebo-controlled study, and they enrolled 127 subjects for intention to treat population. So 82 subjects received the extended release diazoxide, and 42 were given the placebo. Overall, the two groups were balanced with respect to baseline characteristics. So the result of the study found that did not show associated with a statistically significant reduction in the hyperphagia score. But when comparing the patient who had a severe or higher initial score of hyperphagia, it did show a significant greater reduction in the hyperphagia score. The secondary endpoint in this study, there were 2 of the 3 secondary endpoints were improved in the analysis. The primary and secondary endpoint were all improved. So the fat mass and global care impression of change. So lean body mass to fat mass ratio was increased significantly in the treatment group compared to the placebo, with a significant reduction in the body fat mass in the treatment group, and a non-significant trend toward an increase in lean body mass. There were no significant change in weight or the BMI in the treated group. And the following were significantly reduced in the treatment group compared to the placebo, which is the serum leptin and ghrelin and insulin. Serum adiponectin was significantly increased in the DCCR group compared to the placebo. And change in HOMA-IR, a measure of insulin sensitivity or resistance, was not significantly significant in the treatment group compared to the placebo. So based on that study, the extended diazoxide was approved for treatment of hyperphagia in Prader-Willi syndrome. So it did show improvement in hyperphagia score in patients who were moderate to severe hyperphagia, but it did not show a significant effect on the weight or BMI reduction yet. So what about surgery? So I found this study. It is searching the metabolic and bariatric surgery for obesity treatment in patients with a Prader-Willi syndrome. So the primary outcome of this study was to quantify the change in BMI after the 3 most common metabolic bariatric surgery procedure that were done in Prader-Willi syndrome who had a severe obesity with BMI of 35 kilogram per meter square or above. So these 3 procedures included laparoscopic sleeve gastrectomy or gastric bypass or biliopancreatic diversion with or without duodenal switch. So the systematic review and meta-analysis was done through July 2022. Inclusion criteria, they included the Prader-Willi syndrome, as we said, the patient with a BMI of 35 or above, and the patient who underwent this procedure and who had a minimal of 12-month follow-up for weight and height measurement. And outcome was a primary change in BMI at 1, 2, 3, 5, 7, and 10 years post the procedure. And this is the systematic review and analysis for the article selection. So they ended up to include 20 articles. In this 20 article, there were 67 patients. So the gastric sleeve patient were 26, the gastric bypass were 10, and the biliopancreatic diversion were 28 patients. The age varied significantly between the groups. So the gastric sleeve mean age was around 12.8 years. The gastric bypass was around 18.4 years. And the biliopancreatic diversion was around 21.4 years of age. But the baseline BMI was similar across all age groups. And here we can see that all of the procedure had a significant reduction in BMI. And we can see that the gastric sleeve sustained the reduction in the BMI up to 3 years. The biliopancreatic diversion had a sustained reduction in BMI up to 5 to 7 years, whereas the Roxanne Y had a reduction in weight up to 2 years only. So BMI reduction was significant in both short and mid-term follow-up. All groups had a significant reduction of BMI at 1 year of age. The mean 1 year BMI change as listed here. So the highest was noted with the biliopancreatic diversion procedure, and the duration of significant weight loss that was longer sustained was for the biliopancreatic diversion up to 7 years. So long-term outcome and weight regain is sparse in this procedure, but trends are noted that, as we said, the biliopancreatic diversion maintained an average BMI reduction up to 7 to 10 years, and the gastric sleeve showed weight regain at around 7 to 10 years post-procedure, and the gastric bypass had a limited long-term data. So in conclusion, of this study, the biliopancreatic diversion showed the most durable weight loss, but requires a long-term as well a nutritional vigilance. So mortality, there was no death within 1 year reported. And surgical complication for the gastric sleeve and gastric bypass were not reported, but with the biliopancreatic diversion, they did report some vernial hernia because this procedure is done as an open procedure, not laparoscopic. And one patient had a small bowel obstruction. Nutritional complication were not reported in these studies. Isolated cases of iron deficiency, anemia, and osteoporosis were discussed. So the surgical procedure does not affect only the anatomy of or restrict the anatomy and the size of the stomach, but it does have an effect on the hormonal level as well. Because we do know, as Prader-Willi syndrome have a high ghrelin level, and with the gastric sleeve and the biliopancreatic diversion, they remove the gastric fundus, which is the primary source of ghrelin. And studies of FONG have showed reduced ghrelin and reduced appetite post gastric sleeve. So metabolic bariatric surgery does more than just restriction. It alters the gut hormones by increasing GLP-1 and PYY, which do signal satiety to the hypothalamus. So in conclusion, obesity in Prader-Willi, it is multifactorial. It is driven by the hypothalamic dysfunction, hyperphagia, altered body composition, and reduced energy expenditure. It does require a lifelong MDT care. GLP-1 analogs do show some promise with evidence of modest weight reduction, improving satiety, better metabolic outcome. But response there are variable response and data are still lacking and maybe will show in the future. The diazoxide extended release is an emerging therapy. It does target the hyperinsulinemia and appetite regulation. The clinical trial have shown improved in the hyperphagia score. Maybe with further investigation and trial, it could be of benefit in weight reduction. Bariatric surgery may be an option, but it is in selected cases, and it should be in a highly specialized center with a long-term monitoring and follow-up, because these patients, as we discussed, do have a unique behavior and physiologic risk. So successful obesity care in Prader-Willi cases do depend until this moment on structured environment with a caregiver that are well trained with behavioral strategy, nutritional control, coordinated endocrine, along with the emerging pharmacological therapy. These are my references. Thank you for listening.
Many thanks, Dr. Alia, for a very comprehensive and excellent presentation on Prader-Willi syndrome. And indeed, we know that the associated comorbidities and reduced life expectancy in Prader-Willi syndrome, it represents a significant therapeutic challenge in the management. So now I think our next talk will be about mastering behavioral changes and lifestyle modifications in patients with chronic diseases like obesity. We have a very new, excellent speaker with us. Her name is Dr. Sumaya. And Dr. Sumaya is basically she's a consultant family physician who specializes in preventive care and chronic disease management, and she's an advocate for lifestyle medicine. And she's a founder of mandatory lifestyle medicine training course for all medical trainees. She's an adjunct assistant professor at MBRU, and she holds Arab board certification in family medicine and MRCP-GP, followed by MSc in diabetes care and International Board of Lifestyle Medicine certification. She's also trained in clinic genomic medicine and genetic counseling. So, Dr. Sumaya, the floor is yours. Okay, thank you.
Assalamu alaikum. Good evening. Is my voice clear?
Yes, please. It's very clear.
Okay. Thank you. It's my honor to present among experts in the field of endocrinology. Thank you very much. So it's truly a pleasure to see that behavior change is now being recognized as an essential topic in our online live education forum, conferences, academic activities. And it's a critical area that deserves our attention, not something to overlook while focusing only on pharmaceutical or surgical interventions. So welcome everyone, and thank you for joining me today as we explore how to master behavior change and bridging the gap between what we know and what we do. So before I begin my session, I'd like to pose a question for all of us. As a professional who holds advanced degree and see patients on daily basis. So we all tell our patients what to do, but how often do we actually help them discover why they should do it and how they can sustain it? So control, can we show the pool of the question, please. Yes, you can pick your answer. I'll give you 30 seconds to answer, and we'll look at the answers afterwards. Okay, so can we show the answers on the screen? Control. All right. Thank you all for the responses. These results are not bad at all. They very least, they highlight a need, and that gives us a great starting point for today's discussion. So let's move to the next slide here. Okay. I think the slide is stuck. Hmm. Sorry, there is some glitch here. I'm gonna stop sharing. I'm share again. Okay. Still. Sorry about that. Let me share my screen then at least. I think we need a help here, control.
Doctor, could you just click with the mouse? Is it moving?
Wait, so sorry. Nope. I'll move from down maybe. Yeah, excellent. All right. So here's our objective for today. By the end of this session, inshallah, you will be able to understand the key behavior for the changing principles and their relevance to the chronic disease and obesity. We're going to identify common barriers to lifestyle modification among patients with obesity and apply practical motivational interview and coaching strategies during clinical encounters. And at the end, we will integrate sustainable lifestyle intervention into routine obesity practice. So, lifestyle and endocrinology. We all agree that 70% of endocrine condition you see in the practice on daily basis is influenced by lifestyle. Moreover, physician behavior influence patient outcome in two aspects. Let me share with you an example. Physician who smokes and he is counseling a patient who recently had an MI to stop smoking. Do you believe that this patient gonna stop smoking? Absolutely not, because our patient is more clever than when we are giving them some advice. They see our behavior first. They know if we don't care about our self-behavior, we will not care about the others' health. Then, studies showed that internists who are practicing lifestyle medicine or lifestyle behavior, they are more comfortable to counsel their patients about lifestyle behaviors. There is another point I want to highlight about the time during consultation. When we consult a patient for obesity, usually in endocrine clinic, what physicians are trying to do is counseling the patient right around 80% of the time of the consultation to 70% is about the medication and the management, while maybe less than 10% about the behavioral change that they are doing. So the time invested during the counsel, sending a message to our patient to understand the importance of the medication over the behavioral change. So before to jump the changes process, I talk about lifestyle. And what I mean by lifestyle, we are going to discuss in detail later on. So why do we need to focus on behavior in obesity? According to the global obesity trends and WHO data, obesity has become a major worldwide health concern. Today, 1 in every eight persons, or maybe 1 in 5, according to the obesity Global Obesity Federation, is living with obesity. One of the key contributors is physical inactivity. About 35% of the adults aged 18 years and above are insufficiently active. This lack of activity combines with other lifestyle factors such as poor diet, sleep deprivation, and bad habits lead to serious consequences such as hypertension, diabetes, and other chronic conditions. So when we look deeper to the root cause, genetics certainly plays a role, but even if someone carries genes associated with obesity, these genes are or less likely to be expressed in an environment where people are physically active and follow healthy dietary habits. In other words, what I want to say is gene loads the guns, but environment pulls the trigger. So we now live in a time where the prevalence of obesity range from moderate to high, and especially in our region, MENA region. As you can see from WHO data, statistics shows that in 2025, the global burden continues to rise and making it even more important to address the behavior drivers of obesity, not only the biological ones. Okay. In IDF, declaration from call for units of the globe in response to diabetes and obesity. Around 43% of the globe who is suffering with type 2 diabetes are attributed to obesity. And according to IDF, which shows that the projection of diabetes in 2015 in MENA region is around 92%. So that can increase the cases, increase the burden in the country, on the healthcare system, patients, and families. Okay, we have reached the point of lifestyle. What are the lifestyle evidence-based factors we are talking about? According to the American College of Lifestyle Medicine, its base pillars are 6 pillars. First one is the nutrition. It's the whole plant-based diet or a whole food. Then we have the exercise. According to the American College of Sports Society and according to the American Diabetes Association, they stated that adults who are 18 years and above should exercise at least 150 minutes of moderate intensity exercise during the week with 2 days of anaerobic exercises. The third pillar is the sleep. At least as an adult, we need to sleep from 7 to 9 hours per day. Fourth pillar is the stop using or avoiding of substance abuse like smoking and alcohol consumption. The fifth pillar is the positive social connection, and the last one is avoiding stress and calming techniques. So if we go to the studies, it shows that 75 to 90% of the chronic disease has been shown to be preventable by lifestyle behaviors. So data are there. We just need to give some attention and use them so we can create the need to the attention of the users. Why I'm talking about lifestyle? It's foundation-based for each specialty. We need to focus on the root cause of the problems. Like if we tackle a disease from the top, it will be more of using the resources. So lifestyle, it's less invasive, inexpensive, natural, and it's usually used in chronic conditions. I'm sharing here with you landmark studies that approved that lifestyle therapy in the field. I have plotted them here. You can go through them and later, but I want to discuss the most important study here is the one on the top. It shows the leading cause of death in US in 2019 to 2023. The mortality data mainly is the top leading cause of the death for people who are suffering from heart disease, malignancies, strokes, and diabetes. So according to CDC data in 2019, heart disease and cancer alone are responsible for 44% of death in US data. Moreover, studies like RCTs and meta-analysis, if we go one by one, there are a lot of evidence showed that it reversed the coronary artery disease. Like one study done by a cardiologist, he's the pioneer in the field of lifestyle medicine, Sir Dean Ornish. He was comparing the intervention of angioplasty and the intensive lifestyle modification to reversing of the coronary artery disease, and fascinating results was showing in this study. Moreover, most of you know about the diabetes preventive program where they are comparing the placebo to intensive lifestyle modification and metformin, and it shows the superior hands of the intensive lifestyle modification. More studies, DASH diet study, which is controlling the hypertension, and Mediterranean diet, like in pre-med trial, it shows that it reduced 30% of relative risk of the cardiovascular diseases. People who are interested in elderly and Alzheimer, the finger study, it's quite interesting for them. It shows that lifestyle modification can reverse the condition in these populations. So why lifestyle medicine is so critical by the targeting behavior change? We can potentially address a huge proportion of preventive mortalities. Okay. Now we reach to the second poll question. Control, we need to show that question if you don't mind. How many of you have seen patients who know what to do yet don't do it? I'll give you another 30 seconds to go for the answers. Okay, can we show the answer, the results, if you don't mind? Okay, fair enough. So education doesn't equal transformation, right? We all agree. So what we need here to understand that, okay, again, it's stuck. I think we need to stop. Okay, now I can move. All right. We need to understand that there are more than emotions, triggers, environmental habit, and motivation plays powerful roles. The amount of time we are investing in educating our patient for medication, like for example, the dosage, the side effect, and the the way we are going to they are going to benefit from this medication gives a message to the patient that medicine is going to cure them without lifestyle modification, as we are appreciating the medicine. So here, according to the Obesity Medicine Association, there are 4 pillars to manage the obesity. I'm going to discuss today about the behavioral part. I want to introduce few frameworks to make the life easier on us as we are running busy clinics. So the first framework is the trans-theoretical model. This approach is usually used in the smoking cessation clinic, and it is used successfully in obesity clinic as well. So this model is showing 6 stages from pre-contemplation, contemplation, preparation, action, maintenance, and relapse. We need to decide our patient is in which stage. So accordingly, our response will be. Let's take an example. Patient who is in the pre-contemplation stage. I'm not ready to change. You will hear the statement, I don't think I need to change my diet or my activity. So our response going to be, we're going to raise the awareness of having high blood pressure and diabetes as a complication of obesity, trying not to be judgmental in front of them and relate the complaint to the current situation. We try to encourage self-reflection of our patient by asking them, how do you feel about your current weight or current health? Sometimes it's quite challenging, but successfully it will happen by you just ask them a very simple bottom line question. Ask them why you are here, why you are in the clinic. They will simply answer you, I'm here seeking for health. Definitely, they are not coming to shop or for beauty or so on, just they will say about health. So this is a key point you can start your conversation with your patient. Moving to the second stage, which is the contemplation. So your patient is thinking about the change. I know I should do something, but I'm not ready yet. So our response will be trying to explore the motivations and the barriers, so the pros and cons of the changing their behavior. We'll try to encourage small steps, like giving small plans, very small plans, not to overwhelm them. So it's easy for them to implement. Like we can ask them, what is the one things you feel ready to try this week? We move to the third stage. If our patient is there, the preparation, like they will tell you, I'm ready to start making change. You'll just go and hit the button and give them the SMART goal you're trying to address with them in the consultation by identifying the support system and resources for them and plan for referral, for example, and the actions. In the action stage, you just reinforce and appraise their changes and so on. Definitely for the relapse, you're going to assure them this is the normal stage. They're going to pass by and make sure that they are not like feeling disappointed in this stage. You just explain to them this is normal. You can go into this stage and we can go back to any one of the trans-theoretical model stages. The second framework I want to discuss with you is the Coombs model. Just forget about the outer wheel, focus on the green wheel and the red wheels with me. The model in the obesity clinic, let's take an example of the patient who want to lose weight but keeps regaining. So here you are going to assess the Coombs model is acronym of capability, opportunities, and motivation. So you will ask about their knowledge and what are the capability. Is he capable of doing it, or there is a barriers for them? So do they don't know what they can and what they can't do? The opportunities you're going to explore with them, the environment, the social support, and the environmental support surrounding them. For example, if there's family member who's supporting cooking healthy food, or a friend, peers who's going with them for exercise, and so on. The motivational part is exploring the patient. Why do they want to do it? So here you are hitting the value of this patient. Why it's important to you? So this is very nice and shortcut way to hit the patient to their plan by asking this question. We'll move to another framework, which all of you know about, the motivational interview. The acronym of this motivational interview is ORS. ORS stands O for open-ended question. So what are the changes you are seeking for today? For example, just keep it open, the conversation with your patient. Don't ask them very specific questions. So let them explore what they want from this consultation. Then A stands for affirmation. You will tell them, for example, you are already taking big step by coming here today. Just acknowledge and give them assurance that they are already taking a big step. Then R stands for reflection. So maybe you can tell them in a way that you want to lose weight, but you are worried about the commitment or time management and so on. So just assure them that you understand what are their barriers. And S is for summarizing and supporting our patient. Understanding barriers, this is a very important point to highlight. Barriers could be a lot of things you can think about. It's quite challenging part. So, for example, there are physical barriers. Patients who are suffering from pain, knee pain, they can't go for exercises, or they are having some sleep problems. They are not having enough time to manage their physical activity. Some medical condition going into hypoglycemia, or patient with retinal detachment. So we should know the type of exercise we're going to prescribe for our patient according to their need. These are very important and crucial for our patient to understand the barriers. Then there are psychological barriers, for example, low motivation, depression, anxiety, and some patient will come with very common presentation of emotional eaters. And I will tell you how we are going to find these patients and how we are going to manage them accordingly. There are other barriers, like, for example, knowledge barrier, or as I mentioned earlier, social or environmental barriers, like, for example, a family member who was not supportive at home, he would keep cooking, adding salt, oil, and so on. So these all should be sorted out. So we can't remove all the barriers, but we can recognize and work with them, not like against them, but just recognize them and just assure the patient that we understand that what they are going through is very important for them. So habit, building sustainable habit. This is very crucial for our patient to understand that sustainability is very challenging, and all of us agree on that. So starting small with micro habits is very important, not overwhelming our patients with a lot of plans and strategies to manage obesity. So creating cues is very important for our patient also. For example, if you are going to the mosque, you can go walking, or if you are going to sleep, don't forget your 10 stretches. These cues will give them a motivation to sustain their habits for longer time. Like sometimes adding immediate reward, patient who is going to walk, we can ask them about their favorite song, and they can play their song during their walk. So these are like immediate rewarding for them. We are a human being. We like to be rewarded. So this act of rewarding will stimulate them to go and seek for this reward every time when they are walking. Accountability. Don't forget that we need support. So sometimes accountability by peers or family member, but even patient himself, if you ask him about accountability and he will tell you, I'm accountable about myself, you can agree on that and feel him that he is capable of doing that. We always expect relapse, and we will tell them, don't panic, relapse is common, but we need to remind ourselves that support is there. We always advise about focusing on the identity, not just the outcomes. So there is a very nice theory of spiral upward theory about appraising our selves, like going to a walk and saying to ourselves, I feel healthy, or I look strong. And these phrases will reinforce us to go for the walk every time we are walking. This is very common. A lot of you is using it already in the clinic. It's a very shortcut way of managing obesity in the clinic. It will not take more than 2 to 5 minutes. If the clinic is really busy, it's five A's management. Usually you ask your patient for the permission of taking this conversation, and we can assess the weight, the behavior, and the barriers, and we can advise, our advice should be clear and personalized to our patients, and we can agree on a plan. It should be smart plan, specific, and to the point.
Yeah. Sorry, Dr. Sumaya, we're just running a bit short of time, so if you can probably just summarize your presentation, right?
It's okay, sure. I think I'm on the last slide. One more
Okay.
slide and we're done.
Yeah,
Yeah.
okay.
Okay. So this is as a summary for the 5 A's. And the 5 A's is usually used in the clinic of the obesity, and the agreement and the assisting our patient for following up and management. So at the end, don't forget, being a physician, self-awareness is very important. Like we are always giving the unconscious bias of the obesity. So be aware about the bias we are giving to our patient, and assuming non-compliance, believing weight is only about willpower, and judging our patient with the appearance, with the habit, with the motivation. So as they are affected, it's going to affect our tone, our empathy, our body language, and the patient trust. So this is one thing we should focus on, and the emotion awareness. So frustration, if not changed, we feel rush in the busy clinic, and sometimes we try our best to overfix the problems. So if we face such thing in the clinic, we need to pause, take a breath, and respond, not to react to our patient in this way. So I think this is the takeaway message. This is the last slide. Behavior change is a process, it's not an event. We try to tailor our intervention to the patient readiness, and we try to partner with our patient, do not prescribe it, and small changes always lead to sustainable outcome. This is a quote I like to share it with you from Sir Stephen Covey. Changes happens at the speed of trust. And thank you very much for your patience, and sorry for taking this time, but I think it's already was late. This is my references, and thank you.
Dr. Sumaya, thank you very much for the excellent presentation. And we know that indeed for all chronic conditions, behavior and lifestyle modifications are the cornerstone of treatment. And as you have rightly highlighted, that behavior interventions can even lead to reduced reversal or significant improvement in chronic disease conditions. I think we're running a bit short of time. We have 15 minutes for a small Q&A session. So I think the audience will just put their questions in the Q&A box and we can ask the speakers the questions. So the first question we have, I think, is for Dr. Fauzia. And the question is that, most ladies who want to lose weight are usually in the childbearing age group. So what methods of contraception will you advise for these patients when they're using weight-reducing medications? Dr. Fauzia.
It's a practical question, actually, because we often face the patients for one reason or other. They were advised to lose weight even before even trying the fertility. For example, people who are going for assisted reproduction. And in those scenario, always there is a chance of getting accidental pregnancies. So generally, the usual advice is always that whatever is the method preferable, considering the comorbidity status and the safest reliable tool, they should practice. And a gynecologist could be the best, like person to advise about that, because all of the medicine, including the latest medication, are not being studied in pregnancy. So a definite kind of contraceptive method should be advised and practiced by those women who wants to lose weight.
What I know is that, all these medications, including the GLP-1 agonists especially, they cause reduced efficacy of oral contraceptive pills. So if you have a patient or a lady on oral contraceptive pills and they start using GLP-1 receptor agonists, so you have to tell them to switch to another method of contraception, especially like a barrier method of contraception, right? And also, when you're increasing the dose of the GLP-1 receptors, these patients should again switch to a barrier method of contraception.
Actually, on the contrary, barrier method is not having a reliable way. It has a very high failure rate. And if we want to have absolute safety, the most common practice method is oral contraceptive or the other form of contraceptive. And to the best of my knowledge, there is no interaction of GLP plus GIP receptor agonist on the contraceptive, no direct interaction and effect on pharmacokinetics. Though it can be because of the associated nausea, vomiting, compliance may have compromised, but associated changes is not documented to the best of my knowledge. And barrier method never we recommend to someone who may have effect of teratogenicity or risk of unwanted pregnancy while the use of anti-obesity medication because of the high risk of failure via that method.
Actually, these, I think, there are the guidelines which are in the ADA 2025, if you want to have a look at them. Anyway, we have another question for Dr. Alia. The question is that, as Dr. Alia has mentioned, that topiramide is basically, it can be used in childhood obesity and especially patients, who have emotional ability and behavioral disturbances. So is it a common practice that, Dr. Alia, are we using topiramide in childhood obesity and Prader-Willi syndrome? And the other thing is that if we are using, can it be combined with the GLP-1 receptor agonist?
It is not a common medication to be used in patients with Prader-Willi syndrome, actually. What I have showed is articles and studies that I have searched the literature and reviewed. So all of these are not commonly used in Prader-Willi syndrome. The traditional treatment for Prader-Willi syndrome is behavioral and food restriction and growth hormone therapy. So other treatment that I have discussed are all tried like a trial and experiment, let's say, because it's not approved for this indication and this group of patients. Because at some point we do reach at like we are desperate to treat this patient because they have this huge hyperphagia. They have this huge seeking behavior for food and aggression toward their caregiver if they restrict the food intake. So this study have tried this anti-obesity medication to check if they have an effect in cases of Prader-Willi syndrome or not. And as I showed, it is only few number of patients that have been tried on this medication, but the effect is not sustained over all these patients as well. So it is not a routine use.
Right. One more question we have from the audience for Dr. Alia. This is about metabolic surgery in patients with Prader-Willi syndrome. So, is metabolic surgery, especially in patients with Prader-Willi syndrome, they have a greater morbidity and mortality compared to the normal pediatric population? Why is it so?
It is a high-risk surgery in these patients because they do have the severe obesity, they do have the obstructive sleep apnea, and a lot of them, they do have the comorbidities, which is a lot of the time the uncontrolled diabetes, like the case I mentioned, the hypertension. So all of these comorbidities, in such case, even in patient who doesn't have a Prader-Willi syndrome, so the combination of morbidity put them as a high risk for going for any surgery and for going for metabolic bariatric surgery. It is a high risk age and a high risk type of patient. But as I said, it should be thought about in a very selective way, so not to be used usually in these patients.
I think the persistent hyperphagia in these patients and the lack of adherence to a diet post-operatively and the lack of self-regulation is very important, right? As compared to other causes of childhood obesity. So in these patients, acute complications of bariatric surgery are very common. For example, they can be gastric dilatation, they can be opening of staples in these patients, right? So this is what studies have shown that in especially obesity related to Prader-Willi syndrome, the bariatric surgery is associated with a lot of morbidities and mortality as compared to other causes of pediatric or childhood obesity. Um,
Yes. Sorry, Dr. Ashma, I cannot hear you.
Sorry, we have one question for Dr. Sumaya also from the audience. The question is that what are the three most important behavioral interventions for obesity management? Dr. Sumaya.
Yes, I'm with you. Thank you for the question. So, if you ask me in another way, what are the best uh, frameworks is used in the obesity management, I will tell you that one size doesn't fit all. So each patient should tailor his management accordingly. Some patients are motivated selfly, so they feel that they can do it and they link it to something they really appreciate, like a value or this is the best way actually to change your behavior to keep it sustainable. But some patients, they don't prefer this framework. So regardless of motivational interview, transtheoretical model, cognitive behavioral therapy, I didn't discuss even this one, which we tackling the thoughts, changing emotion, and that would lead to changing of the behaviors. There is no single model works for everyone. So combining of motivational interview with the habits, building strategies often gives the best result if you are showing to your patient that the behavioral change is equal to the pharmaceutical management and the surgical management for your patient. So if you noticed, my session was mainly targeting us as a physician. the messages you are showing your patient is mainly going to shape the consultation, and the patient will take the messages from this consultation. How much you appreciate behavioral change, he will understand that. So back to the question, the most important is according to the patient preference. It's not to us what we want. According to the patient, what suits him best, and according to his condition to be tailored. If he needs a medication, definitely you're going to give him a medication. If he doesn't need in this time, you give him and show him that behavior change is going work in this time, and we will wait for the next appointment. So it's all individualized.
Just I wanted to share one thing that I was going through the NICE guidelines and principle of care in obesity management and overweight management, and I found that 5 principles from patient perspective, which all the physicians should take into account. The first principle is respect me. The second principle is support me, and the third principle is know my life, right? And the fourth principle is help me when to talk. Yani you should not be a doctor should not be using stigmatizing language, and they should not be using those words and those explanations which the patients don't understand. They have to speak on the level of the patient's mind. And the fifth one is that understand how I feel, and think about it, that how it will impact my life, as also my body image, right, and also my self-esteem. So I think this is very important. And the other thing I want to say is that, just on a layman thing, that there's a rule of three we like for all obese patients. Number one, that they should have 3 meals a day. Number two, they should drink at least 3 liters of water a day till 3 p.m., right? And number three is that they should be walking 3 hours a week minimum. Okay, so this is a thing. I think we can probably take one last question we have for Dr. Fauzia. The question is that, in the, I think the Chinese population and also in the southeastern population, the BMI cutoffs for obesity medications are lesser as compared to the European population. So, do we know that why this is so? I mean, why the BMI cutoffs are lower?
I believe this is ethnicity-based body structure, because generally the Asian Pacific region population are thin by their skeleton, and the distribution of their body mass is different. And if you see around, actually Europeans, Caucasians, African ethnicity, they have a different body composition. And the incidence of cardiovascular and other metabolic disease are noticed to be much higher at lower BMI values in these particular ethnicity based individuals. So that's why the WHO and other organization started using the lower BMI cutoff value to call them obese, because of the prevalence of higher disease in those particular BMIs, that the individuals belonging to South Asians or East Asians, including Chinese or the Japanese or Indians or Pakistani, Sri Lankan, Bangladeshis, the BMI should be labeled as, so we will be warn them earlier and screen them earlier at the lower BMI compared to the other ethnicities.
I think the attendees must be a scholar who has asked this question, because the thing is that usually, what we say is that people of the Southeast Asian ethnicity, they have more central obesity. So what happens is that, that the BMI, they are more prone to cardiovascular risk, as Dr. Fauzias already has rightly pointed out, at a lower BMI as compared to the European population. So usually the BMI cutoffs which we are using for the Southeast Asian population, and the one which we are using for the Chinese population, and also the Afro-Caribbean population, it is 2.5 kg per meter square lesser as compared to the European population. So I think we can conclude. Thank you very much for the excellent presentations by all our 3 esteemed speakers. And now I think we move to a symposium by Servier, and Dr. Adam will present this symposium. And Dr. Adam is consultant interventional cardiologist and adjunct faculty in Muhammad bin Rashid University of Medical Sciences, and he's consultant in Mediclinic City Hospital, Dubai, UAE. Dr. Adam, the floor is yours now. Thank you very much.
Thank you so much. Good evening, everybody. Well, I really enjoyed that evening's education. I've learned a lot today. Thank you, everybody, for sticking around, whoever has, for the next talk. And by invitation from Serbia, I want to talk to you today about management of dyslipidemia. My slides have just disappeared.
आपका खत्म हुआ
उसके बाद ही मैंने देखा अभी मैंने और भी सवाल
Second, my slides don't appear to be big. Right. Can anybody just confirm whether my slides are moving?
Yes, we can see them.
Yeah. Okay, great. So yes, I'm going to talk to you about dyslipidemia management, and I think it's always quite useful just to set the landscape for the geography that we work in, and the prevalence of hyperlipidemia or dyslipidemia in the UAE in particular is very high, and our surrounding countries in GCC. So about 50 to 75% of the population in the UAE have dyslipidemia of some sort. And we're pretty poor at treating it is the reality as well. And so we have low rates of control according to the recommended LDL cholesterol guidelines or targets for the patients. We have clearly low adherence by patients to the therapies that we are prescribing. And there's a general clinician inertia, clinical inertia to achieve the LDL recommended targets. And I always find that physician inertia is an unacceptable trait or characteristic. It's really incumbent on us to make sure that we're aware of the guidelines, that we are aware and up to date with the relevant and appropriate treatment modalities that we have, and that we try our best to simplify those treatment algorithms so that we can improve adherence for the patients to their medications, and thereby ultimately we improve the efficacy of the treatments and yield improvements in the cardiovascular outcomes. So that's what this talk is about, raising awareness and trying to get our patients on the relevant medication so we can achieve the best cardiovascular outcomes for our patients with dyslipidemia. And why do we treat dyslipidemia? Well, we know that it is a major risk factor for developing cardiovascular disease. And the higher your LDL cholesterol, the greater the disease burden, the more likely it is that you're going to have multiple sites of atherosclerotic disease, whether it's coronary, cerebral, or peripheral arterial vasculopathy. And the effect of the LDL on your risk of atherosclerotic cardiovascular disease is determined both by the absolute magnitude of the LDL cholesterol as well as your cumulative duration of exposure. And we're now sort of understanding this or being more aware of this concept of lifetime exposure to LDL cholesterol. So it's really about trying to reduce the area under the curve in terms of your lifetime exposure to LDL cholesterol. So if we follow that kind of paradigm, then the earlier we can start treatment when it's appropriate, and the more aggressively we can start treatment, then we are going to reduce a patient's exposure to LDL cholesterol. And we know from all the various statin trials, and we can add to this graph with non-statin lipid-lowering agents, that the lower the LDL, the better. The steeper curve in green is for secondary prevention. So clearly these are patients at even higher risk and therefore more to gain by lowering LDL cholesterol. The shallower curve is for primary prevention. But the message is very clear. It's a very linear relationship that the lower you can get the LDL cholesterol, the lower the cardiovascular event rate. In simple terms, that's heart attacks and strokes. And if we amalgamate these data from more than 20 randomized controlled trials of statins versus placebo, we get to this kind of headline figure, if you like, that for every millimole per liter reduction in LDL, we will yield a 22% relative risk reduction in cardiovascular event rate. And that's huge. And it's very reproducible, even with non-statin drugs, that if you can lower LDL cholesterol by a millimole per liter or 40 milligrams per deciliter, will yield a greater than 20% relative risk reduction in major adverse cardiovascular events. So it's really, really incumbent that we take on board this message. And what about if we treat patients aggressively and early? And so this is interesting data from more than 40,000 patients from the Swede Heart Registry. So looking at patients who are admitted with an acute myocardial infarction and treated with lipid-lowering therapy. And if we split the data into 3 centiles, so the 25th centile, which was patients who achieved about 0.36 millimole per liter reduction in their LDL, a 50th centile and a 75th centile. And the 75th centile was looking at patients who achieved a greater than 1.85 millimole per liter reduction in their LDL cholesterol from baseline, at 6 weeks, should I say, from baseline. And you can see a very clear separation of the curves in future prognosis. So the earlier and more aggressive treatment of LDL cholesterol sets a patient on a very, very different trajectory of prognosis, whereby there's a significant reduction in major adverse cardiovascular events in terms of cumulative incidence over the subsequent decade. And those curves separate early. And so what we know for particularly acute coronary syndrome patients is that if we can treat these patients aggressively, a priori, from the get-go, we will set them on a much better trajectory for prognosis. And it's data like this that has been incorporated in the most recently updated lipid-lowering or dyslipidemia management guidelines from the European Society of Cardiology. And we have now the addition of an extremely high-risk population. So where before, from the 2019 guidelines, we had low risk, moderate, high, and very high, we now have the extremely high-risk patients. And these are patients with atherosclerotic cardiovascular disease who experience a recurrent event despite or while taking maximally tolerated statin-based therapy. Or patients with polyvascular disease, so coronary artery disease plus peripheral arterial disease, for example. And for those patients, we should try to aim to get their LDL cholesterol less than 1 millimole per liter, so much lower than we've been previously used to getting LDL cholesterol levels down to. And this is not only safe, but is proven to reduce future events. So highly efficacious and safe as well. So there should no longer be any fears about lowering a patient's cholesterol to less than 40 milligrams per deciliter or less than 1 millimole per liter. In the extremely high-risk patient, this should actually be your goal. And the incorporation of combination therapy, so statins with ezetimibe, a cholesterol absorption inhibitor, has been advocated in the guidelines for quite some time now, so nearly a decade, with the American College of Cardiology and American Heart Association in their 2018 guidelines, and then the 2016, 2019, and now 2025 guidelines from the European Society of Cardiology. So when a patient does not achieve their target LDL cholesterol on maximum tolerated statin, we should be adding a cholesterol absorption inhibitor such as ezetimibe in either escalation therapy or in a combination, fixed dose combination pill. And this is just highlighting the fact that no matter what your level of risk, adding ezetimibe to statin therapy should be the next step in trying to achieve a patient's LDL target. And should we wait for failure of statin monotherapy before escalating treatment? Well, no, not really. Why should we? If you can identify the patient's baseline LDL cholesterol, identify their target LDL cholesterol based on their existing risks, you just need to bridge that gap. And if that gap is greater than 50%, then you know that statin monotherapy isn't going to be enough. And therefore, why not start combination therapy a priori from the get-go to achieve the LDL target as early as possible? And if we're going to do that, why not use a fixed dose combination single pill strategy? Because we know that that's going to improve adherence. And if we can improve adherence, we're more likely to achieve our targets. And again, this has been incorporated in the guidelines. So these are the most recent 2025 ESC guidelines. So intensification of lipid-lowering therapy during the index ACS hospitalization is recommended for patients who are already on lipid-lowering therapy before admission in order to further lower LDL levels. And initiating combination therapy with high-intensity statin plus ezetimibe during the index hospitalization for ACS should be considered in patients who are treatment naive, but are not expected to achieve their LDL goal with statin monotherapy. And so just feeding into that narrative that if you know that you need a greater than 50% reduction, start combination therapy as a first-line treatment. And that's kind of based on this graph, which I really like. I think it's really important to know what the efficacy of the various treatments that we have available to us is. And understanding that if we're trying to achieve a 50% lowering in LDL cholesterol, which should be our minimum, of course, when we're treating high, very high, or extremely high-risk patients, you should need to lower the LDL cholesterol by at least 50% from baseline or less than their expected target, with it, whichever is the greater reduction. And so what statins actually do reduce LDL cholesterol by 50%? Well, really, there's only two. It's either atorvastatin at a dose of 40 or 80 milligrams, or rosuvastatin at a dose of 20 or 40 milligrams. And these are the only two statins that are, or statins and the doses, that are likely to yield a 50% or more reduction in LDL cholesterol. So if you know from the beginning that you need to achieve a greater than 50% reduction in LDL cholesterol, then you might as well use combination therapy from the beginning, and therefore fixed dose combination therapy to improve adherence. And this is, again, another, I think, important slide to kind of, not necessarily memorize, but to take away the key messages. And that is high-intensity statin monotherapy will lower cholesterol at best by 50%. High-intensity statin plus ezetimibe will lower LDL cholesterol by about 60 to 65%. And triple therapy, so to speak, of high-intensity statin plus ezetimibe plus a PCSK9 inhibitor, either a monoclonal antibody or a small interfering RNA molecule, will lower your LDL cholesterol by about 80, 85%. And having those kind of numbers and strategy in your mind will help you set the patient on the right treatments from the beginning, and will ease the escalation of therapy as well later on. So you can inform your patients. So going back to the previous presentation of the dialogue you should have with patients, we should get patients on board with understanding where they are, what their level of risk is, so help them or show them what their risk stratified risk is, show them what their baseline LDL cholesterol is and where their target LDL should be, and help them understand that they have to bridge that gap, and this is how we can bridge that gap for them. So they have an awareness of the treatment and an expectation of what the next step should be, and that helps ease the conversation, the dialogue with the patient, so that they're not resistant to escalating therapy if needed in order to achieve their targets. And so when we add ezetimibe to statin, so in this case rosuvastatin, we know that it yields much greater reduction in LDL cholesterol, and much more so than if we were just to double the dose of the statin. And if we take, in this case, rosuvastatin 20 milligrams plus ezetimibe 10, which is a fixed dose, as you know, in combination, we can lower LDL cholesterol by nearly 65%. So it's a very potent therapy and an excellent choice, in particularly the high-risk patients who need to achieve a much lower LDL target. But this is pooled analysis of statins versus statins plus ezetimibe. And what you can see in terms of across the board, we get statistically significant reductions in the relevant adverse lipid parameters. Some increase in the HDL levels, but on average, we get about a 15% further lowering of LDL cholesterol by the addition of ezetimibe to statins. And as I mentioned before, adding ezetimibe to a statin is a much more efficacious strategy than doubling the dose of statin. When we double the dose of statin, on average, we might get about a 7% further reduction in LDL cholesterol, at potentially the expense also of more side effects. But by adding ezetimibe, we get on average about a 15% lowering of LDL cholesterol with no real increase in adverse side effects. And sometimes patients will ask you, when you go on a statin, when you intensely lower LDL cholesterol, does it cause the plaque that's already there to regress? Does it go away? Well, it certainly doesn't go away. But if we look at IVA studies, intravascular ultrasound studies of coronary arteries, we can see that it does reduce plaque burden, plaque volume. And if we look at data from various studies, that the more intensive lipid lowering, so the lower you can get the LDL cholesterol, the more you will induce some degree of plaque volume reduction or regression. And so while you won't turn a 70% stenosis down to a 20% stenosis, there is a degree of plaque regression, plaque volume regression when treating with high-intensity lipid-lowering agents. This is an interesting study, a randomized controlled trial of high-risk patients, so patients with atherosclerotic cardiovascular disease requiring high-intensity statin therapy to achieve an LDL target of less than 70 milligrams per deciliter, which is 1.8 millimoles per liter. And this was nearly 4,000 patients randomized to either high-intensity statin monotherapy, so in this case, rosuvastatin 20 milligrams once daily, or moderate-intensity statin plus ezetimibe, so rosuvastatin 10 plus ezetimibe 10. The primary endpoint was a composite of cardiovascular death and cardiovascular events and non-fatal MI. And then there were secondary endpoints of percentage of patients achieving their LDL target. And this was it was a non-inferiority study, and it achieved that status whereby moderate intensity statin with ezetimibe was non-inferior to high-intensity statin monotherapy. There was in numbers a reduction of cardiovascular events in the combination therapy arm, although not statistically significant, but the study only was taken out to 3 years. And to probably show clinical or statistical significance, the study should have been maybe extended to longer, because the patients on moderate intensity statin and ezetimibe were far more likely to achieve their LDL target goals. 75% of patients would achieve their LDL target on the combination therapy versus about 50 to 60% on statin monotherapy. So if you're much more likely to achieve your LDL targets, and if you're much more likely to adhere to the therapy as they were in the moderate intensity arm, so there's a much lower discontinuation rate, then we are much more likely to have aggressively achieved LDL targets as well as sustained LDL targets, which in the long term are likely to yield more cardiovascular benefit. So in summary, the take-home messages are that reduction in LDL levels is linearly correlates with plaque regression and improved cardiovascular outcomes. And of that, there is now no doubt. That's pretty much scientific fact. Despite individual variations, the magnitude of LDL reduction by statin monotherapy and other lipid-lowering combinations is very predictable. So have in your mind that understanding that statin monotherapy at best is a 50% reduction. Statin with ezetimibe can yield about a 65% reduction, and then triple therapy with a PCSK9 inhibitor on board can reduce your LDL by about 80 to 85%. Treat to target, so understand the risk, stratify the patient, understand their level of risk, high, very high, extremely high, understand what their target LDL should be, and bridge the gap between baseline and target. So select the initial prescription that is most likely to achieve or reach the LDL target. And if that means combination therapy a priori, then why not? And if you're going to do that, fixed dose combination, single pill strategy is much more likely to improve adherence and therefore achieve your goals. So the combination of statin and ezetimibe leads to further significant reductions in LDL cholesterol versus statin monotherapy, and results in significant reduction in the risk of cardiovascular events. And using single pill fixed dose combinations will improve adherence, which again, we know will improve outcomes. So I've rattled through that. I'm happy to take any questions if there are any, but thank you for your attention, and thank you for the invitation to be part of this excellent meeting. I really enjoyed it.
I think it's an extremely comprehensive presentation, Dr. Adam. One thing I wanted to ask that, if we have bempedoic acid available here, for example,
Yep.
we have certain people who are statin intolerant, right? So
Correct.
in these patients, what to give? What is the modality of treatment? We
Yeah,
know
so
that in
so bempedoic acid is the new kid on the block, I suppose, from oral therapy. You can expect about a 30% reduction in LDL cholesterol with bempedoic acid. It's a good alternative to statin in patients who are genuinely statin intolerant. What I would say with statins, because of the wealth of data that we have, 4 decades worth of data of efficacy and safety, that definitely retest or retrial your patient, re-challenge your patient who maybe has felt that they are intolerant of statins. And if they truly are, and some people are, then bempedoic acid is a good alternative. It can be used along with ezetimibe as well, and that also comes as fixed dose combinations too. So again, the combination of bempedoic acid and ezetimibe might yield about 40 to 50% LDL lowering. So it's definitely something to add into the armamentarium of how we manage lipid level.
Thank you very much, Dr. Adam. And I think with this, we can conclude our session for today. I would like to thank all the attendees who took out time in their evening and attended our Young Leaders Forum. And a special thanks to all the esteemed speakers, including Dr. Fawzia, Dr. Alia, Dr. Somaya, and Dr. Adam. I think thank you for attending the Young Leaders Forum again, and the CME will be available within 4 weeks after the webinar, and details will be sent to your registered email address to obtain the CME credits. And the webinar will be available on demand on the EDS Institute website and the EDS YouTube channel. I think before we can all leave, we can switch on the cameras and maybe we can take a collective photo for the Young Leader Forum meeting today. Before we go, I think we have other activities which are organized by the Emirates Diabetes and Endocrine Society. One is CREATE, which is a learning initiative by EDS and Sharjah University. And we have a presentation on the 11th of December 2025, and it is on ethics in action for clinical trials. After this, we have another collaboration from Emirates Diabetes and Endocrine Society with the American Diabetic Association. And this is about making diabetes technology work. And again, this is also a CME accredited program, and 3.5 CMEs will be earned by attending the course. And I think to further on, we also have the Emirates Diabetes and Endocrine Congress, which is coming on the 6th to 8th February in Dubai in 2026. And I think this is an excellent forum in which all the esteemed endocrinologists all over the world and diabetologists will come. And it is an excellent learning opportunity for all of us. So please attend the Congress. And I think you can increase your academic skills in this Congress. Thank you very much once again. Thank you very much, all the esteemed speakers, for coming and sharing your presentations on this forum.